Welcome to everyone this afternoon. Welcome to our meeting here at County Hall. This is the Health Overview and Scrutiny Committee on the 11th of September 2024. This meeting is being broadcast live to the public via our YouTube channel and will be available viewing on the YouTube section of our website after the meeting. So please, when it comes to making a point of asking to speak, if you can press your button as you start, and then when you actually finish speaking, if you can turn your button off, that's because the cameras in this room locate onto your microphone when it turns red. But please do remember to turn them off, otherwise I will be frantically waving at you in my usual style. Otherwise, we're not expecting a fire alarm. So if there is an alarm, it means the building is on fire, so please leave in a civil way. Exits are marked in each of the corners. So, and I've also got a note here to say that when you come out of the meeting, if you turn right, go through the double doors, down the flight of stairs, which leads to the 2 fire exits. This is actually very precise information, Ewan. Which makes me slightly nervous that you actually know something that we don't. But anyway, we will hopefully run through the next 2 hours without having to make a run for the fire exit. So, as usual, welcome to our Cabinet Lead Member for Health, Louise Richardson. Welcome to you. So, let's start with item 1, minutes of the meeting held on the 5th of June 2024. Is everyone happy that those are true and accurate record? Good, thank you very much. Item 2, question time. We have received 6 questions from members of the public in relation to Lutterworth Health Services. 3 from Juliana Foster and 3 also from Jean Burridge. The questioners have been provided with written answers as usual, provided by colleagues through NHS and elsewhere, and written answers have been published on the website. Now, I understand Jean unfortunately can't appear online, can't join us for the meeting. She has raised a question on clarification on one particular issue. I'm going to ask Ewan whether he can actually go back outside of the meeting to respond to that one item. However, Juliana Foster, I think, has also asked to ask supplementary questions in relation to the 3 items that have been raised before. So if you'd like to come to the table and ask those supplementary questions now, or alternatively, if you wish, you can actually supply them in writing, and Ewan will be able to actually respond to them. Okay, if you'd like to, there's a microphone, any of the microphones, and if you wish to press the red button. Obviously, we are also covering this item later on, so hopefully those questions, if they can't be answered immediately, we'll come to them during the agenda item, and our guests will be able to hopefully respond to them there. Alternatively, once you've actually listened to the meeting, if you have any additional questions, obviously you can respond with any additional items that you hear from the meeting. So there's many opportunities to ask questions, but these are supplementaries obviously to the ones that you've already asked and the answers that you've been provided. So over to you.
Thank you very much. A supplementary question in response to the answers that I was given to my question number 1, which I thank the ICB for. I just want to point out, well, I don't know whether the board is going to follow this because it's a supplementary, but we were in this position. We were told last September 2023 that funding was available for the proposed changes to healthcare services in Lutterworth. A year on, and we are being told that the ICB are now having to consider the implications of having less capital funding, and as a result are developing a medium-term capital plan. In the meantime, the 10 inpatient beds have been closed at Fielding Palmer Cottage Hospital, and the decision-making business case will be finalised and presented to the ICB board later this year for their final decisions. The change in delivery of service at Fielding Palmer Cottage Hospital, thus closing 10 inpatient beds, refurbishing the hospital to provide more outpatient and diagnostic clinics, legally required a public consultation to be held by the ICB under the directive of NHS England. So given that Scrutiny was told a year ago that funding for the scheme was available, and we are here yet again, what assurances can you give that the funding will be made available, and what the residents of Lutterworth can expect on the delivery of the proposed services and in what time frame? Supplementary, I'd like to also put forward for the answer that I was given to question 3. And again, thanks to the ICB for that answer. My question was regarding following the public consultation and the questionnaire. Quite a lot of respondents raised concerns about the care at home and care in a care home. I asked about this, in my question. So the answer was ensuring high quality services, maintaining continuity of care, exchange of information when transferring patients from one service to another, requires investing in high quality training of staff. Given the national shortage of staff within the NHS, how confident is the ICB that this delivery of high standard care will be achievable? Thank you very much.
Thank you very much for that. What I'll do, given that we've actually got the item coming up, I will ask, as part of the opening remarks from the ICB, I'll ask them to address those 2 supplementary points, if that's okay. Okay, thank you very much. And thank you very much for coming to our meeting today. Right. So with that in mind, we'll move on to item 3, which questions from members, which no questions have been received. Item 4, advise any other items. There are no other items to discuss. Declarations of interest. Do any members have any declarations of interest? Betty, your usual. For the benefit of the doubt, it's family relationships in the NHS. Excellent. Thank you very much. Any other? Ross?
Yeah, well, dentistry doesn't appear on the agenda. Just one thing to declare that work for the NHS in the dental domain.
It does appear in one of the papers, though. So I think with that in mind, one word, I think that's worth a declaration. Thank you very much. Brendan?
And daughter who works for the NHS.
Brilliant. Thank you very much. And for the rest of us, I think we visit the NHS on a regular basis. So I think that qualifies for declarations as well. Okay, thank you. So, right, we're now on to item 6, declarations party whip. I'm assuming there are no declarations of party whip. No, good. Okay. So, presentation of petitions. There are no petitions. So we move on to the main agenda, which is item 8 to start off with. Winter planning. We have colleagues here from the Integrated Care Board who have presented. So if you'd like to come up, anyone? We won't bite too much. Thank you very much. Okay, so we've got Rachna, who's obviously Chief Operating Officer at the ICB, and also Sarah Smith, who's Head of Emergency Care NHS England. Is that right? No. I'm notorious for this.
Apologies, I'm Sarah Taylor. I'm the Deputy Chief Operating Officer at University Hospitals of Leicester.
So the first bit, the Sarah bit, was right. That's at least I've got that bit right, which is a first for me. So welcome, Sarah. Thank you very much. Okay, so thank you very much for the 2 of you joining us. Now I'm just thinking about the cameras. I'm sure they'll be okay actually, because normally are we okay with cameras?
They'll still zoom in.
Fine, that's okay. That's okay. Technology is more advanced than I am. So look, we'll always take papers as read. So we have all had a chance to read through the presentation that you've sent through to us. So that's great. Thank you very much for that. If you'd like to start with a couple of comments on anything in the report that you want to actually flag or highlight, please do. Otherwise, we'll then go on to any questions or points that anyone wishes to actually make within the meeting. So who wants to start? Is that you, Rachna, by any chance?
Thank you, Chair. We are bringing today an update on where we've got to with planning for seasonal variation. I know we've called it winter planning here, but we haven't really seen much of a dip this year in terms of demand for urgent emergency care services. So the paper has outlined how we have, in our usual fashion as a partnership across health and care, designed the services that we're expecting to put in place for this winter. They cover 3 areas that we have labelled flow in, so anybody who is going into a service and making sure that the people can access services safely, flow through to make sure that we as the NHS and our care partners are as efficient as we can with the care that we provide there from a quality perspective, and flow out, meaning that anybody who is leaving a service, the risk of readmission into those services is absolutely at the forefront of our mind, and we have made sure that we've got service provision to make sure those people are safe in their own homes when people are discharged from either our UHL, LPT or our EMAS services. The Chair, I mean, what we've done is we've outlined in the bullet points on page 12 of your pack the very specifics that we have taken this year, which is really over and above some of the work that we did last year. We have put into place all of the learning that we took into last year. So you'll see there a big emphasis on admission avoidance in particular, and investment in the community services and our care services to make sure we can keep people safe at home before they hit an acute site. And then in particular, making sure we've got their discharge grant and the Better Care Fund services, which this committee is well appraised of, to support our people when they are discharged from services. We've had a good set of results from last year, particularly on outflow. So for Leicestershire County Council area, about 93% of patients who've gone through our reablement services at the moment are safe at home 91 days after discharge. This is really important from a quality perspective so that we know that those discharge services are working as they need to. We have got some work to do to make sure people, particularly as soon as they are medically fit for discharge, as we discussed last year, are out as quickly as possible and as safely as possible, particularly if they need onward care from my partner care services from local authority. But we continue to work in partnership to make that happen for people. If I may just ask Sarah if she's got any comments, Chair, to add to what you've got in the paper there.
Thank you, Rachna, and thank you, Chair. Just a couple of points to add to that in terms of the infographics that are detailed as Appendix A and B in the pack. You'll see that they detail the plans that have been put in place at the beginning of this year. So as well as developing proposal around core surge actions that we'll be putting in place during the winter months, we do have quite extensive urgent and emergency care plans in order to improve service provision across all of our citizens. Thank you.
Thank you very much. I'll take Betty first, Dan, and then Ross. If I can ask one quick question before we start. You mentioned at the beginning that you know that there hasn't really been a let off since last winter. So hence calling it winter plan is probably a misnomer in the sense that it's dealing with current issues as much as anything else. There's obviously a lot from this paper that I recognise from last year and the discussions there. And I think probably my question would be, is there anything new? Is there anything that you've added to this plan that actually hasn't existed in previous years that you have decided is going to be needed this year?
I'll start with my list, Chair, and then I'll pass over to Sarah for internal UHL actions. So very specifically, last year we learned that we had people specifically in acute sites who wanted to be home, but B, we could have treated them more safely at home. So we've got an additional set of services, which effectively are our admission avoidance services. So we talked about those last year, but we have got new pathways in place this year. So you remember I talked to you about virtual wards. We have increased the number of virtual wards, we've increased the numbers of pathways of virtual wards, and because of the success of them and the clinical safety of them, we are going into areas such as frailty and PEDS, which we didn't do last year because of it was all too new last year. So we've got new set of services there. We've got a whole load of services in general practice now that are supporting people in different ways, particularly in partnership actually with local authority services. So we have integrated a whole load of services, particularly to make sure that people can have access to holistic care as opposed to individual GP care services. That is almost 300 additional staff in general practice to support those, as well as partnership with local authority services. We've got a fuel poverty scheme this year, which we have built on again from learning from last year, particularly with what you will have seen in the news recently about the fuel payments and those types of things. And we have got some additional services with our library services for safe and warm places, I think it's called, and those types of things. So we've built on all the stuff that we know that worked last year. From a discharge perspective, we've got additional support that we've bought in partnership with our local authorities. So we've got more people and more packages of care that we've used the discharge grant for, and all of that is additional. So whilst we might not have anything shiny and new, Chair, what we have got is we've got the evidence from last year of what worked, and we've built on that.
Thank you. Just to expand on that, so we've expanded our same-day emergency care offering within UHL. We've developed new pathways through there. So thinking about the services at the Glenfield Hospital in terms of the rapid access chest pain services and the expansion of pulmonary embolism services over there and how they're accessed. In addition, we've opened elements of those services, and we're in the process of opening elements more directly to healthcare professionals and our ambulance colleagues so that patients can be conveyed directly to those services. So they were in place, but new pathways have been brought online and new services have been developed. We have already opened up some new capacity at Glenfield as well, with the addition of another ward over there. Again, it was built on from last year, but opened in this year. We're just about to start piloting a number of 7-day services, so building on some of the learning within UHL from the industrial action about weekend provision particularly, and how we progress patients through weekends, and the staffing models and rotas from that. We're going to learn from that during the next few months and build on that as then we go through. And that's something obviously that isn't just about winter, but will kick in, so to speak, in winter and develop further. Some new frailty services coming online as well, with the frailty SDEC provision being put into place and piloted, and again in a way that we can learn from and developed. We're supporting our health professionals with a single point of access and onboarding more services. So that gives our health professionals, be that our ambulance services, our GPs, our health visiting services, direct access through what we call clinical bed bureau in UHL, but it's a single point of access, and how we deflect patients directly into services. And then we've done work around children's services as well, so developing some rapid access clinics, developing some same-day services there, and we've done quite a bit of work reorganising the bed provision in order to try and make sure we've got enough capacity for winter. It is going to be a challenge, our bed capacity across UHL for both adults and children, but it's about how can we make sure that we continue to do elective activity at the same time as managing those winter pressures. Those children need their operations, and so we've got to think about that in terms of the way we utilise beds as well. Thank you.
Thank you very much. Right, I'll take Betty, followed by Dan, followed by Ross.
It's quite a general question, really. We've really good community pharmacies out there, and I just wonder, I mean, I know mine in particular, if you go in, they're very, very helpful. I just wondered whether or not we're publicising enough the work that pharmacies can do to help and support surgeries. It's just a general question to see what more can be done to publicise that. Thank you, Chair.
Would you like me to answer one by one? You're absolutely right. And actually, I'm very excited about this. 8,000 people have been through that Pharmacy First programme so far, and very, very few of them, almost 0.01% of them, are then referred back to the GP. So the bounce back rate is really quite positive there. We've also just had some data in yesterday to say that our local pharmacies across Leicester, Leicestershire and Rutland, I don't have the Leicestershire number, but for LLR, 6,500 blood pressure checks have been done in the first 4 months of the year through our pharmacy colleagues, and we're picking up people who are therefore likely to have heart attacks and strokes further down the line and putting them on the medication. So some really, really positive stuff. We've been working very closely with the local pharmacy committee as well to make sure that not only are pharmacists trained in this way now, so that we've got a pipeline in the future, but also working with the universities to make sure that the children who are coming through, the young people who are coming through that pipeline are also trained in the same way. Your question was specifically about publicising some of this work. So we've just, yesterday, we did a similar presentation with our city colleagues. What became very apparent is that we've used multiple channels to in our NHS world, we think, get that message across. But you're absolutely right, we should be doing far more collectively. And my colleague Jenny, who's sitting behind us here, is the Deputy Chief Officer Communications, took an action to work across Leicestershire and Rutland with our communications lead to make sure we've got every channel that we are using across the public sector to be talking to our citizens in the most varied way possible, using everything that we've got in print, everything that we've got in the media, and every channel that we've got. So we should see some of that come through.
Thank you, Mr. Chairman. I would like to say good afternoon and welcome to you first, and thank you for your introduction. This is Scrutiny. I just have some concerns, so if I can just voice those to you. Chairman first mentioned it looked similar to last year, and that would be my thoughts entirely. I've got 2 pages of short paragraphs, flows in, flows through, flows out, 1 or 2 about disability learning, etc. And then 22 pages, coloured picture pages of expressions of this and that. And I just think, well, what does it really mean? What is this all about? It just looks as though it's a massive pad out, because we scrutinise, we look at things, we check things. And on face value, just looking at this a few days ago, I felt quite despondent, thinking, well, where's the story? Where am I going to get into? What are we doing? It's just, well, I say repeat, very similar. And then some of your 3 headings, you know, you more or less say, well, you flow in, you throw fluid through, and you flow out the other end. And there's little bits in those little paragraphs. But I mean, it's not beyond, you know, no revelations here. I don't know what you're doing here. What is it? I mean, the pictures are fantastic, brilliant colours, and there's little bits here and that, building success, and I've got all this there, and something else telling me priorities, and, you know, really, what can I hang anything on? What can I scrutinise out of those pictures, unless I'm unhappy with the colour or the shapes or whatever? But real proper scrutiny, coming before and saying, this is what we've achieved, these are our activities, this is what we're trying to do. And it doesn't really give me anything to be able to scrutinise. So I'm disappointed. I just wonder, your time in preparing all this and the costs associated with our time sitting here today, will it value the public? Are we now adding value to a project or a piece of work by endorsing it or scrutinising it and saying, well, if you turned it this way, or can you explain that to me? So that's my first look at it, and I've looked at it several times now, and for about half an hour before I came into the meeting, I just cannot understand, you know, what am I supposed to gain by this? Thank you, Mr. Chairman.
So Chair, so you'll recognise that the winter plan itself here is described over the course of 2.5 pages and 2 infographics. The rest of it is the vaccination plan, but those 2.5 pages belie an enormous amount of detail and work that sit behind it. The winter plan itself is 3-4 sets of documents effectively that we work on collectively. So I apologise if you were expecting the full winter plan. We were asked to put a summary on the table, which is what we believe we have done. What I will say, though, behind all of this, we're not expecting anything shiny and new, actually, because this is an evidence-based plan on what we know works for this system and has given us the results that we have thus far talked to this committee about previously, and where we have failed, we have learnt from those, and that's within the plans. I appreciate you're saying that detail is not here and therefore you can't see it. The actual winter plan, Chair, if that's something that this committee wishes to have a look at, we are absolutely happy to provide the detail of the plan, which talks very, very specifically on numbers and expectations and metrics and all of those types of things that you would expect in the full winter plan. We were asked for a summary, Chair, which is what we've brought.
Thank you very much, Rachna, for that confirmation. I'll ask for it to be circulated, if that's okay, Dan, and then you have a chance to look at that. Absolutely, yeah.
Thank you, Mr. Chair. Yeah, that sounds wonderful. Now, I'd love to have been sitting looking at that and scrutinising it, because then I've got something to compare, actuals, expectations, performance figures. That's really what we do. But anyway, thank you for your kind offer. Thank you.
Okay, thanks a lot. If it's possible, provide the link, Rachel, and we'll through Ewan, and we'll get it circulated to the committee for information. Thank you very much for that. Ross, I think you're up next.
Perfect. Thank you, Chair. I've just got a couple of points to go over as well. This question may be a little bit off topic. It's not particularly linked to a winter plan, but it's about staffing, because all the projects that we've got on this report are going to require staff to run them. So my first question is, how confident do you feel that you've got the staff in place? And if we're not at full staffing levels, should that not be included in the winter plan as well? You know, ideas on how we could increase staffing levels.
Chair, if I start with an overview and then I'll pass on to Sarah for any specifics. And I repeatedly labour this point because it's really important. The evidence base that we've now got for this plan is built on previous years, which means that those services are already in place, which means we've been able to go out to recruit and talk to people to say, this is what this service does. These are the outcomes that we've been either got or not got and are aiming for, and therefore come and work for this service. It has been a really successful model of workforce recruitment, actually, because we're able to say what we're aiming for. It's not just a title of a job that we're putting out anymore. This is the very specific nature of the job. Also, what we've got is with the integration of services that we're seeing across health and care and UHL and LPT and GPs and secondary care, we're able to offer people a far more holistic care offer, if actually. So from a training and education perspective, people are wanting to work for our system because we're breaking down those barriers. That's very generalist, but the services that you've got in this paper, we've got the workforce either in the plan or already in place, and large volumes of people that we are working with are no longer agency. Actually, they're substantive workforce because of our local economic growth that we are trying to work with our local partners with. So it's in the plan, but that's a very general and generic answer, I appreciate, which I'll ask Sarah to do anything specific.
Thank you, and it's absolutely point noted. You know, we aren't awash with staff, both in the NHS and in social care. And it's really important that actually one of the elements we've not touched on is about the well-being of our staff and looking after those staff that we have got. So there are plans in place about how we do that and how we make sure that we note the well-being of all of our teams across all of our providers. In terms of the plans, we've been fortunate in terms of the nursery recruitment, particularly within UHL, and we've got some good plans afoot, and we're confident that where nursing staff are required to either open additional capacity or care for patients in additional capacity, that we've got those in place. There are some risks to our plans, particularly around our therapy staff. But if we don't develop a plan and we don't understand what we need and we don't strive to put that plan in place, we're never going to achieve it, right? So we do have risk, and we do need to make sure that we are looking after our staff in order to attract our staff, in order to fulfil that risk. So, you know, there are elements that we know that we need to work a little bit quicker on, and we need to attract those staff to come and work here in LLR in order to provide the best service. But I think for me, in summary, the majority of our plans will be delivered with our workforce this year, but there are a few elements that we need to attract more people for, let's say.
That's really good news. You know, we have had reports in the past, and you hear it in the news nationally, don't you? That it's a real difficulty right now to recruit enough staff for NHS services. My next question is about point 11 in the report, and I'll just read out a sentence for you, if that's okay. It says, this is around those suffering from mental health issues, and it says the intention is to grant fund small projects that can help promote the mental health support and awareness of services that are available to people during the winter months. That sounds very similar to what we do at the County Council with the local area coordinators. You know, have you tied in with what the County Council does with those LACs? You know, because I don't see is there much point in grant funding new projects when we already do that relative. I mean, I'm sure Louise will agree, we do it very, very well.
So local area coordinators and mental health and wellbeing neighbourhood leads now are working effectively as one joint team, which is really good news. So all of the work that we do is done in that spirit together on those neighbourhood footprints. We can absolutely strengthen that going through as we learn more about each other and more about how we work together and what the objectives are, but they are working as single teams. We've seen some really good things happening actually. So if I give you the example of Charnwood, in the Charnwood area, the local area coordinator, the mental health lead, the primary care network lead, and our LPT community hospital lead have been working on a project for the refugees and asylum seekers and how we get people into work as opposed to going all over the country without a solid foundation. Now that might seem strange as to why that's linked to mental health, but actually the people that are coming through that pathway are linking the ability to provide for their family directly to their mental and physical health. The way that they've worked together is with no additional resource. They've just come up with a pathway and they've been implementing that pathway. So this is basically building on that kind of work. The grants themselves are working with the voluntary sector. I believe, and I would go back and double check this, but I believe we have been talking to our county council colleagues about how we do that best without destabilising the process that we've already got in place, and to make sure we've applied the learning of any small grants that we have previously given and perhaps not got the best value for money with. And Justin Hammond, who's our lead, will do that through the Leicestershire Place group.
My final question is my final question, I promise. Where do you think the stumbling points are going to be with the winter plan? You know, where do you think the biggest difficulties are going to be to carry out?
For me, it's I might have a slightly different answer to Sarah, but it's going to be demand. At the moment, we have got levels of demand that are growing. So that not only demand of on services, but the demands of our public and our citizens. We've got, as we well know, a finite level of capacity, and at the moment, our capacity and demand we can see on a day-to-day basis. At some points, we need to tweak that. All the things that we outlined today are to make sure we've taken that surge into account. But at the moment, that surge is growing faster than we can keep up with, both in the wider NHS, actually, not just for Leicestershire and Rutland. And this applies to my care partners as well, from an adult social care perspective. So that, for me, is the biggest risk in this, by and large.
I absolutely agree. We are seeing levels of growth that we would be seeing in winter, which is a worry as we go into that phase.
Because supplementary to that in that case, specifically, are there certain areas where you're seeing that surge compared to other areas, or is it just in general?
Chair, do you mean in terms of services, or do you mean people coming from particular areas?
I think I'm probably meaning services, unless you're going to tell me it actually is a specific area, in which case that's interesting as well.
So we have seen growth in every part of the system. So my general practices at the moment, we are offering almost 11.5% more practice appointments than we were last year, but we've still got a level of growth there that we can't meet. We know that from all of our patient feedback. From an ambulance service perspective, they've seen growth which outstrips their current capacity as well. So we've had to put additional support into the ambulance service. I'll leave Sarah to talk about UHL specific services, but equally my care services, so the ones that I do in partnership with my local authority colleagues, equally have seen every part of that service from reablement through to care has also seen a similar level of growth. So it is absolutely across the board. And actually what we're seeing is a far higher level of need in people. So whereby before you could perhaps solve an issue in a day, it's now taking 3 or 4 days because of the complexity of what we are seeing from a disease burden perspective.
Sorry, before Sarah comes in. So in all sorts of ways, I mean, that's fascinating response. So the analysis of why that's happening, where does that lead you to?
So we've done a piece of work across what we've called our Health Inequalities Support Unit, which is an independent set of people who look at what's going on across the system. So the report that we've had so far is showing various things, as you'd expect, that access to general practice is not as good as people want it to be, and therefore people are automatically thinking with their feet and going to a service where they think they are going to get a support that they need. We have seen an absolute increase in acuity. So post-pandemic, our university colleagues are telling us that we have seen an increase in the overall disease burden in the population. They haven't been able to put a cause on that yet, but there is further work going on to understand that, particularly for the Leicester, Leicestershire and Rutland, each place specifically to understand the reason. And there is something about working patterns and consumption of care which has changed. That's been changing for a number of years now, but we are seeing that manifest more certainly with our student population, with our young professional population and our factory population, all of whom wants to access services in a very different way to the way that the services that have originally been designed. The stuff that we've put in the winter plan actually takes all of that into account specifically because we've seen increase in hours of service as opposed to just increasing per se. So we've been tried to be really targeted, which is why I keep saying it's an evidence-based plan, because that's what we believe we've done. We've taken what we know and we've tried to put the service in place to support it after we've talked to those people who are using those services.
And obviously it's going to be really, really interesting to actually see the outcome of some of the research there. I mean, particularly the last bit that you mentioned about different ways of access, I absolutely understand. And I think probably post-pandemic in all sorts of areas of society, I think the way that service provision has moved, I think has been sped up by decades in many instances, owing to what happened through the pandemic. The point on disease and illness intensity, I think is fascinating, and I think again opportunity you're actually comparing that not only regionally but also probably internationally will be very interesting to see whether there's something very specific about the pandemic and what came out of it, or whether actually it's a UK issue or even an English issue versus the four nations within the UK. So I mean, some of that would be fascinating to actually maybe get back once you actually have some of that back, to maybe sort of come back here, because just fascinating to see how some of those issues can be tackled. Sorry, Sarah, you were probably just going to come in with a whole bunch of other bits and pieces.
No, it's okay. Very similar to Rachna, really. We've seen an 8% increase in our ED attendances, which is over 8,000 patients just in the first 4 months of the year. Pretty significant numbers. Our eye casualty attendances are up 10%, with just short of 1,000 patients again in the first 4 months of the year, and a 14% increase in admissions. And that's across all of our services. So 4,500 patients more being admitted than planned. So you can see with those kind of numbers the pressure that therefore that puts the services under, and that's across a range. So some of that is linked to acuity, some of that is linked to increased conveyances that we're seeing, some of that is just patients walking through the door because they can, because it's always open, and they've not been able to get into other services. So it's a complete mixed bag, but it just gives an example of the kind of percentage increases we're experiencing at the moment.
Okay, fascinating, thank you. Arda, on this one? Okay, if you want to ask supplementary.
It was just to take the opportunity to share that Healthwatch has been approached by Richard Mitchell so that we can share the patient experience with the winter plans and the emergency care. So just to alert you that we're involved with that, and both as Voluntary Action in Leicestershire with some of the mental health work and the learning disability work through the voluntary sector as well. So I just wanted to bring that to your attention, and thank you.
Thank you. Mike, do you want to go next?
Yeah, up until those sort of last few comments, I was quite optimistic, but it went downhill pretty quickly with the amount of demand you're mentioning. I suppose with a free at the point of contact system, the demand, is there that wouldn't be there in another healthcare system, say in another country. So, it's a victim of its own success. When you say having enough beds available in the flow through, when you say beds, do you mean the people that go with it as well, the staff that go with it, or do you constantly have to adjust staff? I mean, you must know from previous years roughly, but I would say roughly what's going to come through, but you mentioned ever increasing demand. And is that generated by the inability of people to get to a GP? I know my stepdaughter works at a surgery in the middle of Leicester, and it's a very sort of transient surgery base, and a lot of them can't get in, and it's very easy for them just to go down the road straight to A&E. But I don't know how you stop that flowing. That must be really hard to do, but how do you? And I've got another question on vaccination.
Shall I start with that one, Chair? So You're absolutely right. It's a perennial issue, isn't it? Every year I come to you with an ever increasing number, and the next year it always gets bigger. This year our focus actually has been on what we've called colloquially the Right Place, Right Time programme. So, for example, Sarah gave you the figures from an A&E perspective in terms of what we've seen in growth, but also about 1,000 of those people who turn up to that front door, we are sending away with a booked appointment at an urgent treatment centre or an urgent care centre because the A&E is not the right place for them. And people are actually reacting reasonably well to that. So we are actually trying to not only put people in the right place at the right time and support our staff in the emergency department, we're also hoping to help educate our citizens about where else they can go, because some people just don't know that they can go to these places. So it's about 1,000 patients a month we're sending away. That's one thing. What we're doing with the ambulance service is almost a similar thing on the phone with patients who are not don't have life-threatening conditions. So what we're doing on the phone now is we're working with our 111 colleagues and all the other services that we commission, which are admission avoidance services, to get those people into that right place first, rather than going through an ambulance service, being picked up by an ambulance, then going to the A&E and then getting to the right place. So, for example, we've got one service called the Crisis Response Service, which we work with local government with. The ambulance service can now directly work with that service rather than having to go through that entire pathway and then accessing that service. So where possible, we're taking out all the extra steps where safe to do so. And so right place, right time is kind of what our focus has been. The next logical step for that for us by this winter, we're also expecting those types of phone access points to have access to the virtual wards, have access to our geriatrician services, have access to our frailty services, so that we are trying to minimise the amount of people turning up at that emergency department. Everybody goes to the right place the first time, and not these multiple layers that we seem to have built over the course of many years.
That's useful to know, thank you. On vaccination, it's getting back to basics a bit. Take-up rate is not massively good across the city or the county. Rutland seems to outperform the rest of them. And come vaccination time, which we're coming up to now, the pharmacies are fighting over themselves to get a jab in you. Your GP services likewise. And the GP set up these clinics, mostly on a Saturday. Who are they staffed by?
As far as I'm aware, they will be different practice by practice, but they are usually staffed by what they call HCA, so healthcare assistants and practice nurses who provide the vaccinations. We've also got additional services that are in the community this year, based on learning from all the other vaccination work that we've done with Mike and colleagues about making sure we've got those roving vehicles. So they are going to very specific sites. You'll see in the pack there's a whole list of the September schedule, and they've been really popular because actually we're going to people rather than expecting people to come to our services. So we've got as many options as possible open. It's general practice, it's pharmacies, it's the roving vehicle, and quite frankly, as you say, anywhere else that we can get to increase that uptake, we will absolutely use.
Okay, so forgive my ignorance, but these healthcare assistants, wouldn't they be better utilised elsewhere? Let the pharmacists do the jabs.
We have a specific cohort of patients actually who probably need to come to their general practice for vaccinations, particularly if they're multimorbid. They've got lots of different long-term conditions and so on and so forth, and they're quite often opportunistic. So as well as doing the vaccination, they will do all the other checks that they need to at that time to make sure that A, the person has not just come in for the vaccination, but B, they've picked up anything else that they need to pick up. But certainly our pharmacies at the moment are the easiest route to get vaccinated, and any support this commission can give us in getting that message out to your local areas, we would greatly appreciate.
I have to say, mine is my local vaccination centre is on the Belton Road Industrial Estate in Loughborough, which is the least likely, I think, location you'll ever find for immunisation, but it works incredibly well and dedicated to do nothing but this. So it's really, hopefully it's a model to progress. Mike, I think you were about to come in and say something.
I was, but I think Rachna covered it. I was going to say the HCAs themselves it'll be practice staff. But it's, if there's a clinic in a practice, it's practice staff. Pharmacy is pharmacy staff. The roving stuff is LPT, ICB stuff. Yeah.
Thank you very much. I mean, it's interesting. Immunisation is one of those areas that I think probably up until 4 years ago we probably barely covered at these meetings, and now it's sort of a key element. Brenda.
Thank you, Chair. My question you have answered. To be honest, it's about triage and robust triaging. And forgive me, you said 1,000. Was that a year, a week, or whatever that you are guiding elsewhere?
With that particular project, it's streaming from the front door of A&E, and it's about 1,000 patients a month. So every month we send about 1,000 patients, and that grows obviously as demand grows.
So I'm having problems with my red button. Look, I think we've run out of questions. So thank you very much, Rachel and Sarah, for that. I have to say the discussions, we always learn, I think, something new from the discussions. Dan, I know would certainly appreciate more information, which hopefully you'll be able to supply. But with these discussions, and particularly with the papers, it's always good to actually find out something that you didn't actually know before, and also to hopefully for you to actually sort of hear from us as well on what's key points. So one of the things I did discover today for the first time, I think probably wasn't the other thing, is actually what pertussis is. Discovering that Brenda discovered that she's had pertussis twice. Louise, have you ever had pertussis? You see, there we go. It's not just Mike Sandys who actually knows what produces whooping cough. Now, well, I think she knew. I think you tipped her off. So I have to say, appreciate we are lay members. We have no idea what some of these things are. Whooping cough, we've all heard of. Certain other things we haven't. But it's always good to actually learn something new. So thank you very much for that. And we look forward to speaking to you both again soon. Thank you. You take care. Thank you. Right, Louise, you've let me down by actually knowing what it was.
I used to be in pathology, so I do have an understanding.
Yes, that's probably coming across the after effects of somebody who hasn't had an immunisation against it, but very cheerful. Right, so look, we're now on to item 9, health services in Lutterworth. Obviously, so welcome to both of you. We are, now also we should have Rosita online as well, who's our local member. Rosita, can you hear me?
I can hear you. Thank you very much for having me.
Excellent. Okay, I'll come to you in a bit. By all means, wave or appear on screen when you actually want to ask anything. By all means, please do. I'll come to you probably as the first question, if that's okay, Rosita. Okay, that's great.
No, yes, thank you. I will wait to the end.
Oh, right. Okay, that's fine. I will come to you right at the end in that case, that's fine. So we're joined by Sarah, who's Chief Strategy Officer at ICB, and also Sue Venables, Head Engagement and Insights. Thank you very much to the two of you. You obviously heard supplementary questions earlier on from Juliana. So possibly, as always, we take papers as read, but by all means, please take a couple of minutes or so to introduce any key items in the paper that you wish to highlight. But if you could possibly touch on the 2 supplementary questions to do with the beds and medium-term financial case, and also the confidence in high care provision Juliana's raised, that would be good. Thank you very much. But otherwise, over to the two of you, and then we'll open up for any questions, and then finish with Rosita on the screen as the local member. Okay, thank you.
So Sue's going to take us through, because what we're talking about today is the output from the consultation. And when Sue's finished, I'll just pick up on the supplementary questions.
Thank you, Chair. So I'll take the paper as read, but I just wanted to pull out 1 or 2 key aspects. So it was back in from October 2023 through into the beginning part of this year that we did a consultation to understand from the general public what their thoughts were on improvements that we were looking at making down in Lutterworth, and particularly around Fielding Palmer. It was a full 12-week consultation, and we particularly worked with local people down in Lutterworth. I've done a number of consultations across the NHS over a number of years, and I think for me, this particular consultation, there is a big thank you to the public and community in Lutterworth and surrounding area, a whole host of voluntary and community organisations, particularly the Town Council, Rosita indeed, and many other partners got really involved, and they really took the consultation and the commitment to communicating. So I would like to say a thank you to the community. We don't very often, we do have community support, but it's not to the extent. The total number of people was 1,398 that actually participated in the consultation. That was a range of looking at online consultation, but also completing questionnaires in other ways. And that was another key area where the local community really worked at a grassroots level. We had a presence in the library each week and actually supported people to fill out the questionnaire. And other voluntary and community organisations really helped us reach out, including preschool groups, cricket clubs, U3A clubs. There are a whole range of people there that enabled us to be satisfied that we had reached out to all groups, including those with protected characteristics and the vulnerable. So in terms of the response that we got from people, we're asking people a number of questions within the report of findings, which I'm hoping you will have had a chance to have a look through. There's a whole set of equality data in there that lists right from social demographic data right the way through, and also including those people to identify whether they have long-term conditions or whether they are carers for young people or carers for older people, which is really important to the development of these plans. So a key aspect was really wanting to know from people what mattered most in terms of refurbishing Fielding Palmer, a hospital, and also providing more outpatient and diagnostic services there. And that was asked over a number of questions. The large majority of people were in favour of the proposals that we were making, largely because a lot of people told us around travel and transport, it was much less hassle for them, particularly at a time when they were not feeling very well. That travel into, whether it was Leicester or other places, was an inconvenience for them. So those are the sorts of things that they really pulled out at the top of the list as to why they were saying that they supported this. Although it was very small numbers, I think it is important to recognise that there were some people who did make points around they were not as in favour of the proposals, and a lot of that was around the thirst for having inpatient beds at Fielding Palmer Hospital, that in order to implement these proposals we needed to work to an outpatient and a diagnostic model. We also particularly asked people in terms of a range of diagnostic conditions that we were looking to provide there. What else do we need to think about? Is there something that we haven't considered for you or for the people that you might represent? And again, people put their thoughts forward, and as you'll see from the report of findings, the number one thing for us to consider there was X-ray facilities, but there was a whole range of other conditions, family planning, etc. So that was something again that we considered from the report of findings. In terms of the overall confidence levels in terms of implementing a consultation which met what is our statutory and our legal guidance, we are confident that we've actually achieved that, and we're confident that we reached out to all those key populations and have a report of findings that was independently produced as well, that will obviously go forward and is already influencing the key decision business case around this project. So I'll just pass over to Sarah.
Thank you. So just picking up on the supplementary questions in relation to the availability of capital funding, I just want to refer back to the original answer actually. So there has less capital come into the system in the last 12 months than we had anticipated. I think, you know, it's well known locally and nationally in terms of the scarce resource around capital over the last 12 months. So we are having to re-look at our capital plan. And that's why we're going to develop a medium-term capital plan to try and get some planning over 3 or 4 years instead of this 1-year planning rounds that we have been doing before, because capital comes in on a yearly basis. There is some discussion about it coming in on a 3-year basis going forward, but we're not 100% sure about that. So I can't give absolute assurance until that process has taken place. But what we are doing is we're taking the report of findings, developing the decision-making business case for it to come through in due course for approval at the ICB board. Within that, I think what we'll try and do is identify what we can do in the immediate term, and what would need to be done in the medium to long term once the capital comes in. In terms of the second question around concerns about care in home and at care homes, that's something that we do every day in the NHS and particularly in the ICB, working with our local authority colleagues around care homes in particular. There is a approach in place in terms of making sure good quality care is provided. I think if there are any individual concerns about individual homes, then please come through to the ICB and we can look into them. But it's not something that's just for Fielding, Palmer or Lutterworth. It's something that's done every day around care homes and also the providers of care into people's homes. There is a process and a regime in place to check quality. Thank you.
Thank you very much. Okay, I'm going to open up for any questions. Sorry, Juliana, we can't come back to you, unfortunately. So you'll need to actually put in another question through urine. We don't have the option of, you've asked a supplementary, so you can't have the option of actually then coming back in, unfortunately. Well, I think it's dependent on capital availability and the immediate term financial strategy. So I think from my perspective, I think that's the answer that's been given is the answer that's been given. But so I think we'll wait for the medium-term financial strategy to be produced in relation to capital, and that hopefully will actually provide a bit more comfort. But I fully understand if capital is a problem, then the team hopefully will be able to look at that in more detail. Okay, so I'm going to ask for any questions, open up for any questions. Are there any questions? Otherwise, I'm going to go for Rosita. I'm going to go to Rosita in that case. Are you ready, Rosita?
Yes, I am, and thank you very much. And thank you very much to everybody who was involved. The thank you was very much appreciated, and it was actually a good consultation as far as consultations go. It was good partnership working, and if you're looking at your report, the statistic and the responses actually underpin that. Most of the questions that I was asking have actually been asked, so there is nothing else to add from my part. However, I would just like to add that I have been going round in circles over the Fielding Palmer Hospital since around 2000. We've had consultations, we've looked at it over and over again. And this time, I think myself and the community was really hoping that we would see and tangible outcome in the very near future. So therefore, again, I'm disappointed that we are at the stage where we have to wait for the medium-term financial strategy to get details of how much money is available and what we are going to get. So going forward, there will be another meeting, I'm sure. I think there's one in the diary. And I'm sure the community will be taken into consideration, or that their wishes will be taken into consideration when putting a business plan together. So I'm looking forward to that. But I think it will be a very hard pill to swallow for Lutterworth and surrounding villages, the residents and the villages, that this may now again take several years. And with the political climate having changed as well, we have no guarantees of an outcome. So all I can say is, again, thank you, and upwards and onwards. And maybe at the next meeting, we will have a more positive story to scrutinise. Thank you.
Thank you very much, Rosita. I don't know, Sarah, do you want to come back on this?
Yeah, just one point. I did allude to it earlier, but I think what we will do is have a look to see what we can do within the existing building from the proposals that we've got while that medium-term capital plan is being developed. So I'm hopeful that we can deliver some of the things that we have set out in the proposals.
Oh, that will be brilliant. Thank you.
Okay, thank you very much, and thank you very much for the question, Rosita. Look, I'd like to echo Rosita's comments about the consultation process. A couple of people mentioned beforehand that it came across as actually a very thorough exercise. We often see consultations where it's sort of approached as something that has to be done rather than actually a meaningful process. And I think it's quite clear from this, from the breadth and also the thoroughness of responses, that actually it really was quite a meaty exercise to undertake. And you've obviously looked at it through that lens. And hopefully will, as a result, have an impact on some of the things that you're actually looking at, particularly if there are some sort of quick fixes that can be done between now and understanding fully the capital that you have. I would echo Rosita's comments as well, and also Juliana's and others, that this is something that has been, obviously you're well aware of this, particularly this has been something that's been in the offing for a long time. So I think for everyone in the community, and also everyone around this table, to see a resolution to this in a shorter period rather than actually a longer period of time, regardless, would be extremely welcome, I think, by the community and also by all of those who use the hospital. So thank you very much for your time, Sue and Sarah. Thank you very much, Rosita, for joining us, and thank you very much, Juliana, for your supplementary comments as well. Okay, so with that, we're going to move on to item 10, which Healthwatch Leicestershire update. So we already have at the table Hardip. We're also joined by Sarah. So welcome to you, particularly Sarah as well. As usual, paper is taken as read. Thank you very much for providing the level of detail that you have. We will come on to questions and comments in a bit, but if you want to highlight or flag any particular bits within the report that you want to draw attention to, or maybe any updates since the report came in, by all means, please do.
Yes, thank you, Chair. Firstly, I would like to thank you all for inviting me back to share the work of Healthwatch Leicester and Leicestershire. And I did want to just touch on a few points before questions, if I may. Firstly, I would just like to say you will note from the paper that we've been working very closely with our Cabinet Lead Member for Health, Mrs. Richardson, County Council staff and officers, to strengthen the relationship we have with our commissioners and advance and strengthen the way that we share our evidence and impact following your feedback last time around. The paper also clarifies the way Healthwatch Leicester and Leicestershire is funded, its statutory duties, and the involvement we have with both health and social care services when sharing public voice and public experience. Since the last meeting where we were together, we have recruited 3 new Healthwatch Advisory Board members,
One of those will be your new contact and representative for the HOSC. She brings with her a wealth of experience and has already been proactive and has met with the Assistant Director of Social Services and the Health and Wellbeing Board Manager, and I shared her details with you already. Within the report and paper, you'll find that I've tried to share with you examples of some of our work, our efforts in ensuring that actions and recommendations are taken forward. And I really hope that you've managed to read some of those reports and examples. Also, since we last met, we have been reviewing the Healthwatch Leicester and Leicestershire service since it moved over to Val. We have gathered and conducted a lengthy piece of work around priorities and listening to the views of the public. This resulted in over 8,000 individual experiences and public journeys, and we used a wide-ranging methodologies to inform that work. This work has been signed off with the Cabinet Lead Member of Health for Health and both City and County Commissioners, and I've listed those priorities for you within the paper. Since our last meeting over the last few months, we've reviewed our business plan, published our annual review, and published a further 12 reports. We've planned in for the rest of the financial year 34 enter and view visits, looking at GP practices, care homes, and other health and social care provisions and providers. I really hope that you feel more confident with the service since our last meeting, and I'm more than happy to take questions from you all. Thank you.
Thank you very much, Hardo. So I've got Bessie, I've got Ross. I'm going to start with a very quick supplementary. So you obviously thank you very much for the level of detail, particularly in relation to the report section. I think I'd be interested in understanding what processes you go through to identify the need for particular reports, whether it's by third parties asking for a report to be written. You touched on obviously slightly earlier talking about Richard Mitchell and UHL and the need for engagement through there. So from a sort of reporting and a research perspective, often what happens is, you know, an organisation would look at the reporting structures that are out there, the data that's out there, and identify a particular gap that maybe has not been researched up to now and therefore needs a report. So the reports that are coming out, what's the process that's gone through to actually identify what is going to be reported on, what's going to be researched?
So some of the work around the priorities and the trends and the themes that we look at will enable us to make decisions on the reporting and the research that we will be undertaking or conducting. What we do have is almost a leeway in that, because we do plan for new items or urgent items that may need looking at. So with Richard Mitchell, yes, because of the seasonal planning and the winter planning, there is scope to look at urgent and emergency care. Within our interim view visits, we've already planned 34, but there's scope for where there may be intelligence from both CQC, Health and Social Care Services, County Council, and they might want us to visit other providers. So the reports interim view reports can only be published once the provider has signed those off. Other reports are published in partnership with our commissioners and with their approval and sign off. There is always data and intelligence that we are gathering. And as long as there are recommendations and actions that we are suggesting, a report would be published. Sometimes the timelines may delay things because we are waiting for sign off and approval. And that's where I think the last time I came, we mentioned critical friend. What we don't want to do, although we do have the powers to, is publish something without providers having an opportunity to work with us on their recommendations for improving services, and so that the public feel more reassured. I hope that answers the question.
No, that's helpful actually. So how many of those reports are at the request of sort of commissioners, and how many are actually commissioned directly by yourselves?
50-50. So we share the ones that we've commissioned with the commissioners and also the requests that come in. For this financial year, I would say it's 50-50. Would you agree, Sarah?
Yeah, if I just add from a commissioner's perspective, I think because a lot of the reports come through have the ability to grow organically and can be quite story-led, intelligence-led, then obviously what Healthwatch would do would be to come back to the commissioners and sort of say evidence is suggesting that this is an area or this is an area that may need to be pursued. And then the process would then be that ourselves and city colleagues would contact appropriate colleagues within the organisations to double check that that's not already happened.
And so if it's coming from the county or it's coming from city, the commissioning part of that is Mike's team, or is it another team within the county or the equivalent in city?
That is a combination. So we've got myself, I sit within the Chief Executive's Communities team within the Chief Executive Department. And then we have the Head of Service for Delivery from the Public Health Department, who is supporting, and commissioners from that department. However, we've got contacts across all affected services. And the City Council they are the lead commissioners. They have a similar model. They have a lead commissioner from their public health team, but they also have adult social care as well.
Okay, so it would be the adult social care or public health that are effectively going to be the commissioning parties. So it would either be somebody in Mike's team or somebody within adult social care. Okay, thank you. Right, if I go to Betty, followed by Ross in that case. Betty.
Thank you, Chair. It's the issue of people trying to book GP appointments. It seems to be quite an issue that's on the rise, that people are really struggling to get an appointment with their GP. As GPs own their own businesses, I'm not quite sure what more can be done. Is there anything you can suggest to try and improve that service for people? Thank you.
GP access is actually one of our priorities for this financial year. We are going to be working with the ICB on that work. Some of the, I guess, areas that we're going to be looking at is we are working towards a coordinated and a collaborative approach with our ICB colleagues. So although we have our own surveys that we would go out to and feedback to GP practices, what we have agreed is that we will be doing some coordinated focus sessions around the ICB improvements for the 8 a.m. rush, so that we can share what's working in the county and share best practice. We know that there are some county areas that actually manage GP appointments well or better than our city areas. So we want to share that intelligence. We're going to be also working with the ICB on the recent survey that I think we've got the headline findings, and I believe that they've shared those at the joint HOSC, just to follow up on some of those questions again. And working with the ICB on whether an increase in appointments is actually having an effect or not, because it doesn't seem to go away when we are engaging with the public. GP access and appointments is one of the sort of common themes and trends that comes out. So although there is a lot of work happening around appointments, we are working with the ICB to see whether the public feel that is really the case. So there's coordinated efforts and work happening with GP practices in our own right as Healthwatch Leicester and Leicestershire, but also with our ICB colleagues, so that we're looking at improvements and it's more collaborative.
Chair, the reason for asking that question really is the fact that if people can't get access to GPs, they go to the walk-in centre, and that adds extra load on the walk-in centre. So there must be a way maybe to manage it all better. I'm not sure what that is, but hopefully something can be resolved. Thank you.
See, I think first person who invents a system that manages better than the current one, I think probably will get a Nobel Peace Prize. So thank you for that. I apologize. I should have brought in Louise, because I think you were actually about to, some of the questions I was asking, you were about to comment on those, so apologies.
It's no problem. I was just going to say that it's important to recognise that Healthwatch has its own board as well, so there will be decisions made through that board. But we have joined up through our working together, we've joined up the commissioning more so that public health and communities come together on that, so that we're trying to line up the work that Healthwatch are doing so it can input early enough into our work schemes through the joint health and wellbeing strategy, so that we're tying up a little bit better. And it's been very good, the work we've been doing and the way we're partnering up on that. So thank you, Healthwatch.
Louise, can I ask her a question in that case? Do you feel this working relationship is new in the last 12 months? I mean, is this something that has happened since Val's involvement with Healthwatch?
I think there was a lot of movement with staff, lot of changes. I think we're on a better footing now with the people we have. You know, we're working very well with Kevin and Hardip and Gemma and Harsha. So I think, you know, we're all on a similar wavelength now. And I think it's stabilising better, which means that we'll be able to work alongside each other a lot better.
That's useful information to have. So thank you very much for that. Ross.
Thank you, Chair. Going on from Betty's point about GP access, I don't know if we've all seen the email that came into the council at 1 p.m. this afternoon. It does set out several things that Hardip mentioned about the projects going on, talking to residents and users of the system on GP access. Would it be possible to get a copy of a report to either circulate via email or to discuss at a future meeting once that's done?
Yes, we would be happy to share that intelligence and bring that back.
Well, and then my second question was more of a general one. I'm just curious if you could pick out your bit of work that you're most proud of that Healthwatch has done over the last year, which one would it be?
I think Sarah and I might share a different sort of success or added value than some of the Healthwatch team might, particularly Gemma, the Healthwatch team manager, who's very invested and very involved. If you were to ask her, I think that she might talk about the work with asylum seekers, because this was both city and county. If you were to, as you're asking me, and we're both here, I think some of the work around the changes that we've made to the UHL Accident and Emergency Service, the work that we're doing with County Council colleagues on supported living, because I feel those are often gaps or services, I wouldn't say ignored, but they just tick along and they just run along, and that's where the added value is. But yes, so people might take that personally, but my opinion is those services that run fine on the surface, but when you start digging a little deeper, when you start speaking to carers and their families, I think that's where Healthwatch brings the most added value. I don't know if Sarah wants to come in with her thoughts, if you don't mind.
Thank you. I think I would echo that, but also I was going to say pull out the work around supported living. As a commissioner, I think that's a really good piece of work in demonstrating how Healthwatch can be agile and evolve. So what started out as a piece of work with a start and an end might seem interesting that we got to the end and it hadn't finished, but actually what happened was there was a lot of insight into, I'm going to use, for example, getting the person's voice who actually counts rather than maybe a carer or somebody else in the room who might normally speak. Really important that Healthwatch have adapted and come up with some new strategies, and we've been able to extend that piece of work, recognising that it's not easy, and so the opportunity to get that kind of insight might not come up on actually that regular basis, but to be able to spread that out and work in new ways over a longer period of time, but at the end of it to get a better quality output, I think is really important.
because Brenda and your close colleague Ross, are you happy with that, or Brenda, were you going to ask Ross to ask a supplementary?
Her excitement at something or opinion might not be the value added, and I think that's what we were talking about before. Can I just make a comment, because I don't think we gave you an easy ride several months ago. Was it 12 months or 6 months or whatever? Sooner than that. And thank you very much for responding. And it sounds like you're collaborating better, working towards things better. I've just got one criticism about the plethora of papers that we've got here. I was really bamboozled reading it, and I think it would be better with more focused information for us, because I was reading the same thing over several sort of focus groups, and it was hard to sort of dissimulate what I was reading about. So probably in future, more is less, or less is more. That's it, less is more. So thank you very much.
I think what we have here is Baby Bear and Daddy Bear, and what we're looking for is actually Mommy Bear in the middle, I think, on the basis of level information. So apologies, Dan, if you're Daddy Bear, but there you go. I understand Brenda's comments about the quality, the quantity of information. I also appreciate that given the nature of our previous discussions, you were probably wanting to lay out absolutely everything on the table. So I think we're now at the position, having seen everything. The next discussion probably is back to focusing on where we are. So that would be really helpful. So thank you very much. Are there any other questions from any bears? No. Okay.
This porridge is far too hot.
There we go. So look, thank you very much, Sarah. Also, thank you very much, Hardip in particular. Hardip, I know you're going to be sitting there carrying on because we've got a couple of items still to come. So Sarah, thank you very much for joining us. And we now move on as a result to Brenda, your daddy, Baby Bear, whatever. You're still got your no. It's off. Ross, get her fingers away from the button. Right, okay. Thank you very much. So look, we now move on to item 11, which is the draft Health and Wellbeing Board Annual Report for 2023-24. This is obviously looking back at where we've been, and so thank you very much. Joshna is joining us, as well as obviously Mike has magically transferred from one side of the room to the other. And Louise is here as well as lead member, so, and also chair of the Wellbeing Board, more importantly. So thank you very much for bringing this paper. Again, a huge amount of detail in the report. So thank you very much for that. There will be no comments from anyone in the room about the level of detail on this report. So thank you very much for that. Likewise, if you want to spend a couple of minutes highlighting any specific items or updating us with any information that maybe has appeared but hasn't made its way into the report, then please do, and then we'll go into questions and any comment. Thank you.
Wasn't intending on going through the report itself, just to provide a bit of background. So, as we've said already, it's to present the draft Health and Wellbeing Board Annual Report and to seek your feedback on the content. And it's to provide a snapshot, really. It doesn't capture all of the work that's happened in the past year, but it is about that snapshot of the work that's taken place. The annual report itself isn't a statutory duty in terms of producing one, but it does, I think it does provide a valuable opportunity to showcase the work of the board to our partner organisations and, more importantly, to our residents. What it also does is that when we talk about health and wellbeing matters, we often quite hear it across LLR. And what this does is it brings it back to Leicestershire. So I know it sounds obvious to say it's about Leicestershire coming here, but I think we are keen to highlight the work specifically happening across Leicestershire and recognising the importance of place in that health and wellbeing arena. In terms of the the content in the report, what we've tried to do is provide a description of the role and the membership of the board, bearing in mind the audience that we're trying to reach out to, a description of the statutory responsibilities that the board has, and then the main section of the report is progress against delivery of these statutory responsibilities. And that progress includes a description of successes, a description of challenges, case studies where we've been able to provide those to bring it to life, and then plans for the next 12 months based on some of those challenges and gaps. And then the report concludes with a looking forward section that looks at the work that we're planning to do for the next 12 months based on those challenges, based on the gaps, and based on our statutory responsibilities of the board. Also, just wanted to flag that at a previous committee meeting, there was a query raised around the work taking place on end of life. So there is a specific section within the report, within the annual report around dying well, and I've also included a summary of that within the cover paper. In terms of next steps, the draft report will be presented to the next Health and Wellbeing Board meeting which takes place at the end of this month. If approved by the board at that meeting, the next stage is for our design team to work their magic. As you can see, it's all words at the moment. There isn't that formatting, so that would be the next step for them to work their magic to turn it into something more reader friendly. And also we'll be working with our communications team to promote the report through various channels. And again, in the report, there's some bullet points in terms of how we plan to do that. So an article in Leicestershire Matters, a short video highlighting that, and also when we embarked on this, based on previous years, we've always struggled to receive content, and it's felt like we've had to chase. This year it was the complete opposite. We had an overwhelming response from partnership groups for contributions. So what was going to be a sort of 10-page report, annual report, ended up being quite a lengthy document. So we do understand that might be challenging in terms of putting across the work that's happened. So we will pull together an executive summary, but I think that things like the video will help just to bring the content to life. That's all I was going to say.
Thank you very much for that. Mike and Louise, is there anything to add, or you answer the question?
I think Josh has covered it. I suppose there is why now, because Health and Wellbeing Board is nothing new. Been around since 2013, and Health and Wellbeing Board annual reports. Again, we've published those before now. I'm not quite certain if we've brought them to scrutiny, but as Justin is alluding to, I think it's an important time that people outside of the Health and Wellbeing Board know about the work of the board, particularly in the context of, again, as Joshua was saying, the kind of the ICB LLR footprint, and then what do we need to do in Leicestershire. So it's a bit of a restatement and a refresh, if you like, in terms of making certain people know about the board and its work.
And I'd just like to say that I think it really supports the subgroups to the Health and Wellbeing Board as well. After all, they are the officers doing all of this work, and so I think it's really important that that is seen.
Thank you for that. So my comments would probably echo back some of the points that you've made. I mean, it's a very useful document because, from our perspective, it gives a very clear sort of description of the breadth of the things that the Wellbeing Board covers, and also a better understanding, I think, of probably the interrelationships between some of the subgroups and the way that they're working. To be successful, they need to work well together, but they also need to work well with NHS and the ICB. And it's really important, I think, for the most to be got out of the work that's been carried out, that all of those organisations are working really, really well together and making the best of those links at the most appropriate time. So, I mean, obviously, we've heard a lot from colleagues in sort of other areas today. Can I ask about particularly the NHS and the ICB, or UHL and ICB? How's that relationship? Because obviously this is very sort of complementary. It's not necessarily sort of core functions as far as some of the sort of the pure health areas that they cover. But if this works to be successful, then actually the outcomes will be actually to the benefit of what the ICB and the NHS are seeking to achieve. So just if you can outline maybe for me before we open up for general questions, how those relationships are working.
I think I won't, it's been a challenge in sometimes. Obviously, we all work in a lot of different ways, all the partners around the table. It's been a learning curve for every organisation. We've had to become more holistic in how we look at our own services, just the same as we're asking, the NHS to understand us and us to understand the NHS. I think we're making good progress, and I think there is a commitment and a willingness to do that and to have the seamless services we want to see in the future. But I think the people we're working with are very committed to it. It's how we then take that through our organisations and make sure that the workforces are on board with the strategies and the way we'd like to work within this area.
I think the other bit for me is you can talk about the board and the enthusiasm that partners bring to the board, but actually it says nothing about that working together is almost an entirely different question, isn't it? Always had good relationships with health colleagues. I suppose there's a couple of things I'd highlight, one of which is actually co-location. So having colleagues like Rachna in G30 has been really useful, just to have them on site. So that kind of, we used to in the old days, the water cooler moment, we're not exactly around the water cooler, but at least they're in the same building, has been helpful. And then Josh, I don't know if you want to cover the kind of more explicitly the place-based team that we've been building with, again, colleagues in the ICB, just in terms of below the board level stuff, in terms of day-to-day working or week-to-week working anyway.
Yeah, just to build on that, we have the statutory committee of the board, but I think what makes the engagement happen at the board is the work that's done in the background, and I think that's been building over the sort of last 18 months, and we've reached a point now where we have a place-based, what we call the place-based team. So we have ICB representatives that are part of that that are helping to scope where we see ourselves for the next year. So they're really, really excited to be working with us around what we do with Leicestershire and how that differs from the wider geographical footprint. So it's still in its early stages, but I think to have us all around the table really enthused to do that work together, I think is a really significant step forward for us.
Okay, I've seen a couple of hands so far. I've seen Bessie, I've seen Dan. Any other hands likely to go up? No? Okay, so we'll start with Bessie in that case then.
I just wanted to sort of say how pleased I am with the family hubs that's been set up. There's one set up in Loughborough, my patch, and I went to it. And I have to say that I'm very, very impressed with how it's run. And I think it's a really good initiative, and I hope it carries forward into many other places. Thank you, Chair.
Thank you for that. Any comments, compliments? No? Compliments, everyone just accepts compliments. Okay, Dan. Compliments, Dan.
Thank you. Thank you, Mr. Chairman. Well, you may have heard my comments earlier on in the meeting about reports and subjects, etc. This is totally different. This is what I like. See substance, to see things I can read, things I can challenge in my own mind before I even think of challenging the authors of the report. This is substantial. This is the way I love to see scrutiny. It's there, we can see it, it's well presented, and it's not, and I'd just caution you about reverting to smaller text and masses of pictures. This has meaning. The pictures have very little meaning, and it's not help. This is helpful. The other is just, well, it looks as though it's padding a report out, and I'm not being rude to anybody who does a report like that, but a lot of it tends to be, let's have proper specific information, and this deals with it. So congratulations, well done, thank you very much indeed. It's a good report.
I dare not ask for any other questions, because otherwise it may not be two compliments. We'll leave it there. I think, look, I think we're on safe ground at that point to actually leave it. Look, I'm going to leave it there. So look, thank you to the three of you. Louise, I know you chair this very well, so thank you very much for doing that. Joshua, likewise, thank you for bringing this report to us. Dan's right, huge level of report. Betty's comments likewise, picking up on key items within it, demonstrates. I think all of us have read this in a lot of detail. And I know you flagged at the beginning the point about dying well and emphasising the work that's been done, and it is something I know that's been discussed at this committee before. And it's so important. It's along with taxes, it's the one thing, a certainty that we're all going to be heading in that direction at some point. But the importance of actually making sure that that people are treated with dignity and appropriateness during those stages, not only them but also their families as well. I think it's so important. So I'm so pleased that work's actually gone into that as well, and presented in the way that this has been presented. So thank you very much for the report. Compliments from Dan, so I think go away and just accept them for what they are, which is rare, but very important. Anyone else that Mike?
Yeah, just a thought. Actually, I mean the comments are gratefully received. If it's useful for the committee, and maybe we could feed this into the agenda planning meeting. I suppose I'd like to take credit for all of it. There's only a limited number of things that the board as an entity is responsible for, which is the stuff in section 4 around the pharmaceutical needs assessment, the joint strategic needs assessment, and the BCF. The rest of it, it's the aggregation of the work that individual partners do by themselves all together in their day jobs. So it almost gives a bit of a, sometimes it can be difficult when we get reports about how's it all add up and what do you want to see brought forward. But as an annual report, if it then gives an overview of work going on in Leicester on health, which the committee then might want to sort of have a read through at leisure and then go, well, actually, we want a bit more on that. It might provide a useful role too.
So a welcome annual event. That's basically what you're saying. Yeah, excellent. We look forward to seeing the next one in that case. Thank you very much. Okay, look, thank you very much for that. So we have one item remaining, which is item 12, update on the new model of support for those at risk of homelessness. Mike, you're taking this as Director of Public Health. So obviously we've read it. It's there in front of us. So are there any points that you want to raise? Otherwise, we'll go into any questions.
No, I mean, as the report sets out, it's the committee request to follow on in terms of seeing how the new model was doing. So this is a report on that one. The first part will be familiar through the reports we took in terms of the redesign about the whys and wherefores and where we're up to. Again, I'll turn to Josh. I don't know if she wants to add anything extra to the main part of the report, if you like, which actually the activity data in paragraph 14, just in terms of how the new services got on in the first 6 months. But I don't know if you want to add a little bit of a flavour of, a bit more flavour to the figures.
If it's okay, what I did want to highlight from the report is that was to focus on the comments that came out from the consultation when we put forward the proposal to decommission the service. So there were some concerns raised around lack of awareness of First Contact Plus and local area coordinators. So it was really just to sort of bring to your attention the work that we've done. So I know that's in the report around the road shows, around an article in Leicestershire Matters, and the impact that had on the referrals that we received into the service. Also, there were some concerns flagged around accessibility of the service. So again, the data was to show that we haven't seen a drop in referrals coming through with the new model. In fact, we've seen improvements because new additional needs have been identified from the triage process compared with the referral, the information in the referral. So it was, and then there were concerns raised around capability and capacity of the workforce in terms of First Contact Plus and local area coordinators. So again, just to highlight that we did meet with both teams, and actually it wasn't a surprise really, but they saw this as business as usual work, that they already do this. So they weren't taking on a new role, a new piece of work. So it was just to sort of evidence that we haven't, those mitigations or those concerns that came through, they haven't actually materialised. It is early stages, so I don't want to say that this is here to stay forever, but again, within the department, we do keep an eye on all of our activity and we do tweak services as needed. So really, it was just to flag that bit.
Thank you very much, and that's reassuring to hear. I mean, you know, from the paper and also from your comments, clearly what you set out and what you thought was possible, by the looks of it, has turned out to be the case, which is reassuring to at least, you know, there were no surprises, no shocks to the system, etc. It was within capacity and also providing the level of service that you wanted to provide. So reassuring so far. Are there any questions or comments? Oh, Louise, do you want to come in? Sorry.
Yeah, I just want to say, I mean, it was quite a challenging thing to change this service, and I just want to actually put on record my thanks to Joshna, and Simon is actually in the room, to Simon Dolby, who looks after the LACs and First Contact Plus, etc. I think they've done a brilliant job.
I absolutely agree about the LACs. The contact that I've come across them in Loughborough, yeah, have been fantastic. You know, it is a great team, and has been referred to several times today, I think, probably for the work that it's done, or that they do, and the teams they support. So very, very good. Any questions, Mike?
Just a quick one, Chair. Is there any evidence that people have not accessed the service or have gone elsewhere or just don't know about it?
So what we've done is we've compared it to what was going through the previous service. So on that basis, because it's on par, we don't think that there are individuals falling through, because if we'd seen a reduction, we'd be concerned. But we couldn't say for definite that there may be individuals out there who aren't accessing the support. We couldn't say with 100% certainty. We're just comparing with what was coming through the previous service.
You don't necessarily know what you don't know.
Yeah, yes, exactly. I suppose it's a fair comment, isn't it? I mean, you know, there's some reassurance that it is actually it was better than the previous service, but you know, in numbers wise, it's no worse than the previous service. But there would be a challenge to us, as it would have been to the existing service, which is, are you getting that kind of full county coverage? So, you know, we don't know what's there, but you know, is everybody being covered? I doubt it, but that's the next challenge for us, having transitioned over.
Okay. Thank you very much. Right, I can't see any other hands. So look, again, Joshua, thank you very much for bringing this report. We hopefully, you know, future reports will maybe be on an annual basis, so that we can sort of see how it's doing in the context of all the other services that are provided. But thank you very much also to Simon as well. And also pass on our thanks to the LACs, because as Ross has highlighted earlier on, you know, they provide an amazing service and really invaluable part of what the county does, and particularly on the public health side. So look, that brings us, I think, pretty well to item 13, which is the noting the work programme of the joint HOSC. So that's for noting only. On to item 14, date of the next meeting, which is 2 p.m. on the 13th of November, which is not that far away, actually. And then any other items under item 15, and there are no other items. So at precisely 3:42 p.m, I declare the meeting closed. Thank you.